I guess. This is some old data, but it kind of drives home a key point. It's from 2002, so we're over 10 years old, but the trend is exactly the same. If you'll notice that most diseases have either pretty much stable, leveled off, or are decreasing in their incidence, with one notable exception, chronic obstructive pulmonary disease. I just looked at the most recent data this morning, and COPD and diabetes and liver disease are the three that have a positive increase still to this day. So the bottom line, the good news is you'll have a job, because the incidence of chronic obstructive pulmonary disease ain't going away anytime soon. We're getting better at managing pretty much everything else, but COPD, diabetes, and liver disease were the three that still had a positive increase. These are old numbers. I could have put the projected 2011 data in there, but at this point we saw that there was, and you should be able to memorize those. Good, because you don't need it. But basically, COPD, as of 2007, was the fourth leading cause. Just a little bit of a review what we're talking about here. If you remember back, oh gosh, when was this? It was a long time ago. Back in September, maybe. We were talking about the airway and how it's broken up into the conductive areas and the respiratory areas, where the respiratory areas actually have gas exchanging units present. So everything distal to the terminal bronchiole is considered the acinus, where that includes the respiratory bronchioles, the alveolar ducts, alveolar sacs, and alveoli. I don't know why that screen didn't go down all the way, but alveoli is, I'll add the last one. And the conducting airways would be everything above that point. As far as the airways, also need to just remember the mucociliary component of it, where you have mucus being produced by submucosal bronchial glands, as well as goblet cells, which are interspersed between the cilia. They create this mucus, this sol and the gel layer. The gel layer is the sticky part, which traps particles. Sol layer has the cilia within it, which sweeps the mucus towards the central airways. Also, in that submucosal layer, or in the lamina propria, actually, is the smooth muscle that exists through the conducting airways. Once it gets down to the smaller ones, you start losing that cartilaginous support, and the smooth muscle becomes more prominent in causing airway obstruction. Review? You've seen all that before, right? Okay. So our normal lung, and I like the way Desjardins has these drawings, because they really drive home what the disease is like. Again, we have here cartilaginous airways until you get to the bronchioles, at which point you start having smooth muscle that, when constricting, will reduce the caliber of the airway itself. Ciliated, pseudostratified columnar epithelium, moving down with some of these goblet cells. I'm sorry, these are the some submucosal glands that are producing mucus. And you can see that as you get further and further down, nice airway structure, nice developed alveoli, and the whole 9 yards, right? With chronic obstructive disease, there actually has been a organization. It's called the Global Initiative for Chronic Obstructive Lung Disease, or GOLD. And this initiative is basically designed to review the existing literature, and they update pretty much every year. But as far as how this disease should be approached and managed, there's a similar group for asthma, and we'll talk about that when we get to asthma. But the nice part about it is that they're trying to get a unified consensus on how we diagnose it and how we treat it. Okay, so we will refer to the GOLD standard. If you do go to either the GOLD or the asthma is called the EPR3, do not print them out. They're like 300 some pages. So unless you don't like your printer for whatever reason, you can save it as a PDF and look at it that way. Again, dates back to 1998. The National Heart and Lung Blood Institute, which is a division of the NIH, National Institute of Health, and the World Health Organization were the folks who initially started this. And it basically was allowing, as I said, a classification and treatment methodology. So what is COPD? Well, the key word there is preventable and treatable. It is a disease that can be prevented by getting rid of the risk factors that are present. And it's manageable in the sense that we can control some of the signs and symptoms that exist with it. With some significant extrapulmonary effects, so there's some aspects of it that are outside the pulmonary system, as we'll see, and they contribute to the severity. Its pulmonary component is characterized by, and here's the key part, airflow limitation that is not fully reversible. Okay. Asthma has an airflow limitation that is reversible. In this case, it's not. It's usually progressive. In fact, as we'll find, most patients with COPD are not diagnosed until they have lost approximately 50% of their lung function. So it's kind of a late one. The word I love to use is it's insidious, meaning it just is kind of there deteriorating you, and then all of a sudden you get to the point where you're so screwed up, you go to see your doctor and he goes, oh, you got COPD. Oops. It's associated with abnormal inflammatory response to noxious particles or gases. And when we say COPD, we're primarily talking about chronic bronchitis and emphysema, although those patients with chronic bronchitis and emphysema often have a reversible component to their airway obstruction, so there's some asthmatic component within there. I love this picture because it kind of graphically points out that this world of airflow obstruction, airflow limitation, encompasses multiple diseases, chronic bronchitis, emphysema, and asthma, and in reality there's a lot of them that are overlap. COPD, or chronic bronchitis and emphysema, two distinct defects that exist, but quite often they coexist together. That's why we kind of use the garbage term COPD in the process. Asthma less so, but again it is a major contributor to airflow obstruction. So let's talk about the chronic bronchitis piece first. It's basically just an increased production of mucus. Goblet cells, bronchial glands become greater in number, greater in size, so they're producing more mucus in the process. And the key part to diagnosing chronic bronchitis is a cough with expectoration for at least 3 months of the year for 2 consecutive years. So patients who say they have a morning cough where they bring up mucus and it's there every morning, they have COPD. Okay, they have chronic bronchitis in the process. And we're assuming again that the cough is not from some other cause. Okay, at least 3 months of the year for 2 consecutive years that they have this increase in cough with expectoration. Okay, yeah.
Is the primary cause of that from smoking?
Can you wait 5 minutes?
Yeah.
Okay, good.
I can wait 10.
So characteristically, yes, an answer to your question, but we'll find this. Characteristically, what you end up seeing is a patient who has an increase in mucus production, okay? And that's why the cough is there. If you look at the distal airways, they're fine, okay? So your respiratory zone is not affected so much by this. This is an airway disease, okay? But you can imagine why, with all of that mucus in the airways, why you would have an airflow limitation in the process. The other end of the spectrum, or not the end of the spectrum, but the other component to this is emphysema. And this is an obstructive lung disease characterized by destruction of the terminal lung units, so everything from the terminal bronchial on. at that point. And there's two types of emphysema that you'll need to distinguish between. One's called panlobular, one's called centralobular. Panlobular, pan, all, involves enlargement of all the air spaces distal to the terminal bronchioles, including the respiratory bronchioles, alveolar ducts, sacs, and alveoli themselves. So there's a permanent enlargement and destruction of those structures distal to the terminal bronchioles. If you think about it, it's basically a disease where you end up having alveoli that coalesce together. The walls of adjacent alveoli basically become one, and you end up having, instead of a lot of little air sacs, one big air sac. Exaggeration there, but in essence, that's what you have. Those smaller alveoli have capillaries that are surrounding them. As this process occurs, you lose that alveolar surface area. And in the process, you lose the alveolar capillaries also. So what you end up with is a reduction in surface area. And if you remember back to a Fick's law, talked about surface area being one of the factors involved in diffusion defects. So we're going to find these folks have diffusion defects. The key part here is that this is a genetic defect. It's associated with a loss of a protein, alpha-1 protease inhibitor, or alpha-1 antitrypsin. And in the process, what you end up having is then this protein not being there, the alveoli basically just destroys itself. So here we have an enlargement of that distal airspace. Instead of having these nice group of alveoli, I have basically one big one. Okay, I'll come back to it. Centralobular is a little bit different. This one is primarily the respiratory bronchioles that are involved, but everything distal to it is not affected. So if you want to think of it, it's towards the center of the tree, towards the branches, rather than the actual leaves themselves. Centrilobular. This is the more common form, and this is the form that's usually associated with chronic bronchitis because they have a similar etiology. So centralobular, those respiratory bronchioles are the ones that are damaged. The distal ones, the alveoli, alveolar sacs, alveolar ducts are okay. By the way, in I think it's Canada, they refer to it as COLD, chronic obstructive lung disease. I like it. I got a cold. And as we'll find, it is the cause of smoking. Smoking is one of the major factors involved. Some epidemiology stuff. Again, this is old data, but it's still probably around the same percentage. The far more prevalence of chronic bronchitis than there is of the emphysema component of it. Problem also is that it's hard to get good data because it's diagnosed so late. And as I mentioned, about 50% of the destruction is there before we're even able to diagnose it. It is age related. Obviously, there's more diagnosed at a later age. The exception to that, as we'll find, is the panlobular, which is usually diagnosed very in the early to late 20s, as opposed to the mid to late 50s. Male greater than female, well, no, they're probably pretty close to each other by now. And less education, blue collar. That's also was where the higher level of smoking is present. It is now the third leading cause of death. Surpassed stroke last year. They weren't predicting it till 2020. Guess what? It's already here. The actual incidence and as far as a cause of death, is probably higher than that, but somebody with COPD who has who dies from a heart attack is going to be listed as having MI as the cause of death, where a good component to that as a contributing factor is the presence of COPD. It also is not only as far as a cause of death, it's a cause of disability because of your inability to function. A lot of your daily activities are significantly impaired. Risk factors. Well, we talked about the genetic component of it, and it really is kind of a northern European ancestry seems to be the highest prevalence. There actually, I think there still is a website where you can go and see if you're a carrier of the gene itself as that alpha-1 protease inhibitor. Usually the lungs have a hyper airway responsiveness, and there is some factor with, as we'll see in asthmatics, children with asthma that are not properly treated can end up having some airway remodeling, which could potentially be a precipitating factor to development of COPD in later age. Most of the causes, the risk factors involved are environmental, with tobacco smoke being obviously the most common one, although air pollution and some occupational issues can also be contributory in the process. The perception that everyone who smokes will develop COPD is unfortunately not true. Kind of wish we'd drive the point home a little bit more, but really only about a fourth of patients who smoke develop COPD. We're now finding that there most likely is a high genetic component to having an increased propensity for developing it, but it's not a one-to-one relationship by any stretch. But still, 60 million people is a pretty large number of people. We'll come back and revisit this, but this is the mechanism by which the gold standards go ahead and classify the severity of COPD, and they classify it into one of four stages: mild, moderate, severe, and very severe, by looking at the FEV1 to FVC ratio. And if you'll notice, they're all below 70%. So one of the first things we did when we looked at the obstructive disease versus restrictive disease process, we looked at that ratio. Next, we look at the FEV1, our lung number. Patients in the mild stage are going to have basically normal looking FEV1s. So at this point, there's no airflow limitation present, even though the pathophysiology is there that will, if left unchecked, develop it. Moderate is when you're seeing 50 to 80% reduction in the FEV1. Severe, 30 to 50%, and again, this is where patients typically first present, is they're already into late stage 2, early stage 3. And then finally, very severe is less than 30%, or less than 50% if you have chronic ventilatory failure manifested by an elevation in PaCO2. Okay, so we'll come back and visit this again, but that's the way we classify COPD. And the classification then will dictate what interventions would be appropriate at various levels. So again, stage 1, mild airflow limitation, chronic cough and sputum may be present, and again, they're totally unaware of any problem. Stage 2 is where you have between 50 and 80. There is some starting to see a shortness of breath on exertion, and there is the cough and sputum productions starting to manifest itself. And again, towards the latter portion of the stage is where they start to seek medical attention because of some of the deficits that they start recognizing within their own function. Stage 3, 30 to 50%, more short of breath, poor exercise capacity, dramatic fatigue present, and what we're going to find is that the presence of exacerbations of COPD where they end up having to have hospitalization present, is a marker that A, we're trying to prevent, and B, the more exacerbations, the higher the mortality, or shorter the length of life. And stage 4 is basically the one we talked about being severe limitations. The development of cor pulmonale, where again these are the extrapulmonary effects that we end up seeing, where the right heart goes into failure due to the chronic hypoxemia that is present, increasing the pulmonary vascular resistance. And this is where the quality of life is. You know, the guy has a commode sitting in the living room because he can't get up to go to the bathroom. You can go from the easy chair to the commode sitting next to it, and that's about the extent of what his life is. Yeah.
About COPD. Is that an umbrella term?
Mm-hmm.
So it could be emphysema and chronic bronchitis?
Go back to that.
or both?
Go back to that that Venn diagram.
Right.
Yeah. Could be all three.
Could be all three. All right.
Okay.
Just sometimes I hear a COPD and it sounds like...
Well, you watch all the ads on TV. They say COPD. Blah, blah, blah.
Right.
My Advair works wonderfully for my. Yeah.
Do we normally never diagnose at stage 1? Like, how would you know? Like a stage 1?
Well, okay. Great question. Stage 1, you wouldn't know other than some of the other symptoms that we'll talk about.
And that's not commonly until stage 2 normally?
Right, and this is why we try and get anyone over the age of 40 who smokes, their family physician should be doing PFT tests on them, just to document where they're at. Okay,
So
because there's no marker that appears
right,
early
so
on.
Say by fluke, let's say you have somebody come into the clinic and we do a PFT and it shows normal. But is there anything else that would give me an indication that maybe he's a stage 1, and then do you treat it or do you not treat it?
Well, if you look, what is the treatment for stage 1? Limiting risk factors, getting the influenza vaccine, which most patients would have, and possibly, if needed, if there is an airflow limitation, acting what we're going to call a SABA, a short-acting
Because we did that.
beta agonist.
We gave patients, and one of the physicians I worked for said, go to RT school and learn the criteria because we kind of give a broad in the sense that they're more likely better off giving a bronchodilator in this stage, even though you don't have to.
This is for relief,
Okay.
as we'll find, yes. Okay,
And this is where you would also, if they smoke.
smoking cessation, absolutely, absolutely. Stage 2, the moderate, that 50 to 80% range for the FEV1. Again, this continues for all the groups. So anyone diagnosed with COPD will always, or should always, get the pneumococcal vaccine and should always get the influenza vaccine because those can be triggers of exacerbation. Again, that's the goal to not have. What we're going to add here, though, is one or more long-acting bronchodilators, LABAs, in addition to my SABA. And adding pulmonary rehab, because the impairment here is starting to get pretty significant. Okay, so pulmonary rehab is one of those entities that a handful of you might wish to pursue as a career option. Most RTs look at pulmonary rehab as being hell, because I got a bunch of cranky old COPD patients that I'm working with every day. Thanks but no thanks. But it's a very rewarding process also, because you're watching somebody progress over time. And it's just a cardiac rehab where you have a graded exercise program that exists, and you basically develop mechanisms by which they can go ahead and increase their function. Yeah, increase their function. Getting them to through education components also, which is part of this, teaching them about their medications, teaching them about their disease, teaching them about ways that they can do things that utilize less energy and have better oxygen utilization in the process. Stage 3, again, we're progressing here to a 30 to 50% reduction, and now is when we're going to add our inhaled glucocorticosteroids. I'll be okay. Especially if the repeated exacerbations are present. This is where you start seeing the hospitalizations become a little more frequent. So this is where we would add the Advair. And then finally, the last one, looking at long-term oxygen therapy, looking at possibly some lung reduction surgery. They can actually cut out portions of the lung that are grossly dilated, and possibly even looking at lung transplants, although really it's the panlobular that are more of a candidate for that than of the others. So, what's the pathophysiology? Okay, we know what the pathology of the two of them is. Distal to the terminal bronchioles, the respiratory bronchioles only. Increased mucus production in the case of chronic bronchitis. For emphysema, the permanent enlargement, again, we talked about that being all distal, but if you were to do an autopsy on you or I, the lungs would collapse inward once you cut into the thoracic space. These guys don't. They're chronically hyperinflated, and they've lost the elastic fibers within the alveoli that cause it to collapse. Okay? The term you'll need to recognize is something called bullae. We'll talk about bullae and blebs in a little bit, but they're basically these chronically inflated air spaces where the alveoli have all coalesced together, and they're, I think about a centimeter is a pretty big size balloon, but that's basically what it ends up with. Along with the destruction of the walls, you have destruction of the capillaries. Since I have fewer vessels to pump the blood through, this is another contributing factor to the pulmonary hypertension you end up seeing with COPD. We have respiratory bronchioles collapsing, which lead to the air trapping and hyperinflation that is characteristic of this disease. And if you were to measure airway compliance or lung compliance, you would see it's an elevated number. Again, not because the lungs are getting better, but because we've lost elastic component. Elastance goes down, compliance goes up. And there's also an increase in airway resistance, so they got the best of both worlds. Okay. Bullae, we said, were those air spaces greater than a centimeter in diameter. Once you get towards the pleura, you're seeing these. We have a different term we use for them, blebs and bullae. Kind of a nice little thing to remember. And here's kind of how well that shows up or not. But I think I might call that a bullae or a bleb. Actually, it's probably a bullae. Nasty, eh? So where this is what the normal alveolar capillary structures would end up being, here I just have this one big destruction. One key distinguishing factor between chronic bronchitis and emphysema is that in emphysema there's a diffusion defect. Chronic bronchitis typically does not. So in all else held equal, you're going to see the diffusion issue in emphysema. So some of the things that you end up seeing changes occurring, because I have twitchy airways, I have increased airway resistance. I'm going to have inflammatory changes present, which lead to that twitchy airway. I talked about the number and the size of the goblet cells and bronchial glands being increased, producing more mucus, increasing the airway resistance further. They also have a higher prevalence of pneumonia. We talked about the bronchial wall destruction that is present, and then leading to also the alveolar structures becoming deflated or defective, and hyperinflation occurring. And we talked about the pulmonary capillary destruction leading to cor pulmonale. I think we've talked about this before, but we all lose to some extent. FEV1 goes down as time goes on, roughly about 30 milliliters per year. With COPD, you have a more rapid decline, if person were to stop smoking, the slope of that line goes back to what the slope would end up being. So patients will often ask you, if I quit smoking, will my lungs get better? And the answer is no. The destruction is there. Can't do much about it except prevent further loss. You can get back to where we would normally be, but you've lost that lung volume in the process. So this is kind of one where we end up having a little bit of everything going on. Plugging of the airways, obliteration of the smaller airways, the respiratory bronchioles, loss of elasticity in the structure, and loss of parabronchial support. So it's kind of a nasty disease from all aspects. Three major symptoms: a cough with sputum production, and dyspnea on exertion. And that's kind of what presents often the patient to the ER or to the family physician, is complaints of really all three of those together. Symptoms don't always correlate well with spirometry. So although we use spirometry to classify it, symptoms have to be taken into effect also. The symptoms are not predictive of prognosis, and they don't often reflect responses to therapy. We really should be looking for spirometric changes rather than symptoms. I think in the back there's the 10 Commandments of COPD. My predecessor put those together, so they're kind of neat little things. What ends up happening, or what causes some of these exacerbations, more often than not, it's a bacterial infection, a pneumonia that ends up developing, that it exacerbates the symptoms. There is some correlation with GERD, gastroesophageal reflux disease, where the microaspiration that exists of these stomach contents leads to some airway inflammation in the hypersensitive airways. There's a high correlation between COPD and CHF, both right and left-sided heart failure. And as we'll find, there's also a third one in there that's obstructive sleep apnea. They have a high incidence too. And obviously non-compliance with therapy is going to promote the exacerbation of COPD. There is a substance within your body called elastase that basically is there to get rid of old tissue and kind of, devour it. The problem comes when, that elastase that is present is kept in check by this alpha-1 protease inhibitor. This genetic defect that is present in the panlobular is where you don't have enough of this substance around, so the elastase goes unchecked and just keeps destroying elastic tissue. Okay, so it's really the genetic defect causes an inability of that substance to be there, which then promotes the destruction of the alveoli. It is a recessive trait. It does have some correlation with liver disease also, but the COPD that develops at a very young age. I have a guy I went to grade school with. His wife has been diagnosed with this, and I think she's on a transplant list, but she's mid-50s and can't walk across the room without oxygen. So, no history of ever smoking cigarettes, most of these patients. But there can be a history of COPD. We say it's numbering the lower lobes. And you can measure this value as far as the circulating serum level. And what we end up seeing is a dramatic reduction. You don't need to know those numbers, but just recognize that there's a lab test we can do to identify this deficiency. And I think I'll stop there.